Welcome to the Hematology and Oncology ABIM Board Review. This presentation is designed to provide a comprehensive overview of key topics in hematology and oncology. Acute sickle cell chest syndrome is a critical condition involving symptoms like chest pain, cough, infiltrates on imaging, and hypoxemia. Treatment includes supplemental oxygen, antibiotics, and pain control. Severity dictates the need for blood transfusions as follows. Mild cases with low oxygenation. 90% with a single lobe need 0 to 2 RBC transfusion, and moderate cases with oxygenation, 85 to 90% or 2 lobes involvement need 2 to 3 RBC transfusion, whereas severe cases with saturation, less than 85%, or 2 lobes require exchange transfusion. One important tested part is that incentive spirometry can prevent chest syndrome in admitted patients. Priapism and sickle cell can cause irreversible damage if not treated within 4 hours. Mild cases may resolve with increased fluid intake, while severe cases lasting more than 2 hours require blood aspiration from corpus cavernosum or injection of sympathomimetics in it. Persistent priapism may necessitate surgical shunting, glans spongiosum shunt, to relieve the condition. Patients with sickle cell disease are at risk for stroke-like symptoms. Secondary prophylaxis involves regular transfusion therapy to maintain hemoglobin levels, proving more effective than hydroxyurea. Exchange transfusion is particularly used for acute ischemic stroke, detectable via MRI. Acute severe anemia in sickle cell disease can arise from various crises. Splenic sequestration involves vasoocclusion in spleen causing pooling of blood, and splenectomy is needed to prevent recurrences. While aplastic crisis results from reduced erythropoiesis, which can happen with infections. Hyperhemolytic crisis is marked by sudden anemia due to multiple transfusions, likely because of delayed transfusion reaction. Autoimmune hemolytic anemia can be classified as warm or cold based on etiology and clinical presentation. Warm AIHA is often autoimmune mediated. Warm is with anti-IgG mediated. It's treated with corticosteroids and splenectomy. Warm AIHA can lead to DVTs, whereas cold AIHA, linked to infections, usually more severe anemia and can cause livedo reticularis or acral cyanosis with cold exposure, can lead to ischemia and gangrene. Treatment requires avoiding cold temperatures and may involve rituximab treatment. Thalassemia is a genetic blood disorder affecting hemoglobin production. Alpha thalassemia ranges from silent carriers to severe, more common in Asians, while beta thalassemia is more common in Mediterraneans. Normal adult HbA is 2 alpha and 2 beta. So in beta trait, HbA2 is present, which is 2 alpha and 2 gamma, whereas beta intermediate has high HbF. Red blood cell morphologies provide insights into various hematological conditions, from bite cells indicating G6PD deficiency and alpha thalassemia. Spherocytes rather than schistocytes are autoimmune hemolysis, which can happen in CLL or hereditary spherocytosis. Target cell morphology, which is due to extra hemoglobin, is present in thalassemia, HBC, post-splenectomy, or liver disease. A very tested question of teardrop cell in myelofibrosis, basophilic stippling in thalassemia, iron deficiency, alcohol abuse or lead-metal poisoning, Howell-Jolly bodies, which is retained RBC nuclear remnants in asplenia, or splenic hypofunction like sickle cell. G6PD deficiency is an X-linked disorder characterized by oxidative stress and the presence of bite cells. While G6PD levels may appear normal during acute hemolysis, repeat testing is advised. Understanding this condition is crucial for managing hemolytic episodes effectively. Transfusion-associated graft versus host disease occurs when irradiated blood is not given to certain patients, which is BRO irradiate, that is BMT, immunodeficiency, and relative. It's usually tested by mentioning hematologic malignancy patients getting chemotherapy. Transfusion leads to donor T cells, which can cause immune reactions in immunosuppressed individuals. The classic triad of symptoms includes fever, rash, and diarrhea, often resulting in fatal outcomes. Proper blood irradiation is essential to prevent this condition. Acute intermittent porphyria is an autosomal dominant disorder causing toxic heme precursors buildup. Symptoms include abdominal pain and neuropsychiatric issues. Treatment focuses on removing triggers and administering glucose or hemin infusions to manage attacks effectively. Iron deficiency anemia and anemia of chronic disease have distinct characteristics. IDA involves absent iron, while ACD shows abundant iron in macrophages but absent in RBCs. Long-term metformin use can lead to vitamin B12 deficiency, given it affects absorption of B12 from terminal ileum. Pseudothrombocytopenia results from platelet clumping, leading to falsely low platelet counts. This phenomenon occurs in EDTA tubes and can be resolved by repeating counts in heparin or sodium citrate tubes, ensuring accurate diagnosis and treatment. ITP treatment in adults involves a tiered approach based on platelet counts and bleeding symptoms. No treatment is platelet greater than 30,000. Initial treatments include steroids or IVIG, followed by splenectomy or rituximab for persistent cases, followed by thrombopoiesis-stimulating agent if needed. Evaluating for underlying conditions like HIV and hepatitis C is crucial in all patients with thrombocytopenia, even if it's 90K. TTP involves ADAM-TES13 deficiency, while HUS is often linked to infections. Management of TTP is medical emergency, including plasma exchange and immunosuppressive therapies. A very important question is people can get TTP in pregnancy because of antibody formation. Heparin-induced thrombocytopenia can be non-immune or immune-mediated. Type Y HIT is benign, resolving with continued heparin use, while type 2 HIT requires direct thrombin inhibitors due to high thrombosis risk. Delayed onset HIT poses significant complications, necessitating careful monitoring. Evaluating bleeding disorders involves assessing platelet counts and coagulation profiles. In regards to coagulation profile, if normal, this would need von Willebrand disease analysis or factor IX level. In cases with prolonged APTT, mixing study is done. If corrected, then it's due to factor 8.9 or 10 deficiency or VWD assay is needed, whereas if no correction, it's because of factor inhibitor or lupus anticoagulant. If prolonged PT, WEPT, it's due to liver disease, warfarin use or vitamin K deficiency, or could be due to factor 7 deficiency. Both PT and APTT are prolonged. This could be due to DIC, fibrinogen disease, combined factor deficiency. Mixing studies are essential for diagnosing prolonged PT or PTT. They differentiate between factor deficiencies and inhibitors, guiding appropriate treatment. Von Willebrand disease factor replacement involves specific dosing strategies based on surgical procedures. Major surgeries require higher doses, while minor procedures need lower maintenance levels. Deep vein thrombosis risk assessment involves clinical symptoms and D-dimer testing. Patients with negative USG duplex should undergo repeat testing within 24 hours if high clinical risk. Another tested fact is tamoxifen increases clot risk, so should be discontinued 2 to 4 weeks before procedure. Venous duplex ultrasound is indicated for superficial vein thrombosis that is 5 centimeters or longer, or in proximity to the deep vein system. It is also used when there is involvement of great or small saphenous veins, more lower extremity swelling than expected, or superficial phlebitis following vein ablation therapy. Dabigatran, a direct thrombin inhibitor, requires monitoring through thrombin time. Perioperative management often involves discontinuing dabigatran 48 hours before surgery if renal function is normal. If thrombin time is normal and last dosage time is unknown, surgery can proceed regardless of dosage. Idarucizumab is available for emergency situations for dabigatran reversal. For DOACs like rivaroxaban and apixaban, and ixanate alpha serves as a reversal agent. Warfarin is used when kidney function is compromised, specifically if CRCL is less than 30. It is not necessary to hold warfarin before low bleeding risk surgeries, nor is there a need for warfarin bridging before or after AV valve procedures. However, bridging to heparin is needed for mitral valve issues or VTE or TIA within 3 months or high CHA2DS2-VASc and AFib. Supertherapeutic INR management involves holding warfarin and administering vitamin K. Most cancer types do not increase the risk of intracerebral hemorrhage when treated with low molecular weight heparin, or DOACs. However, higher risk cancers such as melanoma, choriocarcinoma, thyroid carcinoma, and renal cell carcinoma require careful evaluation of anticoagulation risks versus benefits before therapy initiation. The JAK2 V617F mutation is associated with several myeloproliferative neoplasms, including Polycythemia vera, essential thrombocythemia, primary myelofibrosis, and chronic myeloid leukemia. Primary myelofibrosis can be asymptomatic or present with constitutional symptoms like fever and weight loss. Hepatosplenomegaly is a common sign due to extramedullary hematopoiesis. Laboratory findings include normocytic anemia with teardrop cells. Bone marrow aspiration often results in a dry tap. Polycythemia symptoms include increased blood viscosity, thrombosis, and bleeding. Erythromelalgia, which is more with wearing socks, transient vision disturbances, and hypertension are also common. Exam findings include face plethora and splenomegaly with elevated hemoglobin levels. PV patients have increased risk for thrombotic events, post-PV myelofibrosis, and AML or MDS. Polycythemia can be primary due to JAK2 gene mutation, or secondary, resulting from underlying conditions like tissue hypoxia or kidney diseases. Management includes phlebotomy plus low-dose aspirin or hydroxyurea. We hold testosterone therapy if hematocrit exceeds 54%. Essential thrombocythemia is characterized by thrombocytosis, with 20% of patients developing acquired von Willebrand disease. Aspirin is contraindicated, but cytoreduction treatment with hydroxyurea can help manage the condition effectively. Multiple myeloma patients can sometimes only produce monoclonal immunoglobulin light chains, which may not be detected on SPEP. Classic symptoms with negative SPEP findings require free light chain analysis and UPEP for further investigation. Disease progression markers include more than 60% clonal plasma cells in biopsy, free light chain ratio of 100, and MRI findings of lytic bone lesion. Monoclonal gammopathy of undetermined significance has less than 10% clonal plasma cells in bone marrow biopsy, with spike of 3 and no symptoms. Waldenstrom macroglobulinemia involves excess IgM, which causes hyperviscosity leading to blurred vision, headache and vertigo, and infiltration signs, including hepatosplenomegaly, lymphadenopathy, and cytopenia. Eyes can have dilated and tortuous retinal veins. Diagnosis is supported by serum protein electrophoresis and bone marrow biopsy. Treatment focuses on decreasing symptoms and organ damage through emergent plasmapheresis, with a prognosis of 10 years. CLL and mantle have CD5 and CD23 present in CLL, whereas CD5 absent in marginal and follicular with CD10 positive. Hodgkin's lymphoma is identified by positive CD15 and CD30 markers. Chronic lymphocytic leukemia involves more than 5,000 mature B lymphocytes and can present with autoimmune hemolytic anemia. Diagnosis is confirmed through peripheral flow cytometry, and no pan-CT scan is required. Treatment includes steroids, with splenectomy as a resistant option. Indications for treatment include growing nodes, uncontrolled symptoms, low counts, and marrow failure. Chronic myeloid leukemia is characterized by peripheral eosinophilia and basophilia, with 90% of patients having BCR-ABL fusion. It progresses from chronic stable phase to accelerated phase and potentially to blast crisis, requiring careful monitoring. Hairy cell leukemia is a rare B-cell lymphoproliferative disorder with features like cytopenia and splenomegaly. Diagnosis involves bone marrow biopsy and flow cytometry, while treatment options include cladribine and pentostatin. Myeloid reconstitution syndrome is an intense inflammatory reaction post-neutrophil recovery, resembling sepsis or ARDS. Symptoms include fever, rash, and lung infiltrates. Management includes supportive care and corticosteroids, with careful monitoring to prevent abrupt infection onset. Non-Hodgkin lymphoma survivors face long-term complications like second malignancies, which includes cancer of skin, breast, lung, mesothelioma, and sarcoma. So, these patients need annual mammogram after 8 years post-treatment and annual skin exam. We need to evaluate for cardiovascular disease, endocrine disorders including annual thyroid test, and neuropsychiatric issues. Tumor lysis syndrome requires short-term hemodialysis when calcium phosphate product exceeds 70 mg/dL, or in cases of symptomatic hypocalcemia, persistent hyperkalemia, or severe oliguria. Lymphadenopathy can be observed for 3 to 4 weeks in patients without malignancy signs. Persistent lymphadenopathy requires excisional lymph node biopsy to evaluate for cancer. Indolent lymphomas often present with waxing and waning painless lymphadenopathy, necessitating careful monitoring. Understanding the genetic implications of BRCA1 and BRCA2 is crucial in oncology. Both genes are associated with autosomal dominant inheritance patterns, leading to increased cancer risks, particularly in breast, ovarian, pancreatic, and prostate cancers. BRCA1 is notably linked to triple-negative breast cancer, while BRCA2 is associated with male breast cancer. Prophylactic measures, such as risk-reducing mastectomy and salpingo-oophorectomy, are recommended, with age guidelines suggesting intervention by 35 to 40 for BRCA1 and 40-45 for BRCA2. Renal cell carcinoma presents with abdominal pain, mass, hematuria, and weight loss. It can also be associated with paraneoplastic symptoms such as hypercalcemia and erythrocytosis due to elevated erythropoietin levels. Prostate cancer treatment often involves external beam radiation, which can lead to sexual dysfunction as a common long-term adverse effect. Superior sulcus tumors, also known as Pancoast tumors, are located in the upper lung near the subclavian vessels. They present with symptoms such as severe shoulder pain, arm weakness or paresthesias, and Horner syndrome. These tumors are typically caused by non-small cell lung cancer, including adenocarcinoma or squamous cell carcinoma. Carcinoid syndrome is characterized by symptoms like cutaneous flushing, telangiectasia, asthmatic wheezing, right-sided valvular heart lesions, and cramping with diarrhea. Diagnosis involves elevated urinary excretion of 5-HIAA and imaging studies like CT or MRI. Treatment options include octreotide for symptomatic relief and surgery for liver metastases. Patients may also have niacin deficiency, which should be addressed. VA-PAMA, also known as WDHA syndrome, is marked by watery diarrhea, hypokalemia, and metabolic acidosis. The secretory diarrhea persists during fasting and is characterized by a low stool osmotic gap, which is less than 50. It's important to distinguish VI-POMA from carcinoid syndrome, as VI-POMA does not elevate serotonin levels. Flushing and wheezing and R heart valve in carcinoid. Radiation therapy can induce xerostomia, but muscarinic agonists like cevimeline can help save saliva. Fertility referrals should be considered before chemotherapy, especially in hematological malignancies. Intracranial radiation and chemotherapy for childhood. All can lead to secondary malignancies, such as brain tumors, including meningioma and gliomas, and leukemias. For patients with advanced lung cancer, hospice referral may be more appropriate than molecular testing. Thank you for watching this presentation. We hope you found the information insightful and helpful in understanding the complexities of oncology and cancer treatment.